Welcome everyone to our fourth webinar, and we're going to be reviewing chapter 4 today of Com's Take Back Control book. So welcome, let's start.
Welcome everybody. Today the topic is in chapter 4 is dealing with the holistic approach, dealing with the whole person and how important it is to treat the whole person. And in this regard, we have a couple case examples. We thought we'd start out with that.
Great cases. Let's jump in.
So this this patient, Nancy, was actually a 28-year-old. And these are real cases that actually stick with me for years. Nancy was a young, attractive, fit woman in the retail business. A lot of computer work, not much of an exerciser, but did a lot, had to constantly be moving her neck as far as part of her work. So she started developing neck pain. And unfortunately, one day she developed a lot of neck and radiating arm pain, bad arm pain, weakness, numbness. So you start to think, okay, what's going on, right? So she goes and sees her physician, and they note that she has a disc herniation. Now, interestingly, they said this herniation was pretty big. So they told her, and this word "big" stuck with her, right? So it's
compressing the nerve.
Yeah. So it was a disc herniation. So the disc is here. So this is the cervical spine. These are your nerves that are passing.
This is a side view, correct?
Right. So you're looking sideways at somebody. They're facing this direction. Your nerves are the blue, and their disc, they said, was protruding out a lot. It was compressing the nerve, and so she all she could hear was this was big, and it was really very bothersome to her. But then she went and saw a spine surgeon only 3 weeks later, and her symptoms were 80% improved. So she goes, "Doc, but I got this. My primary ordered this scan, and this is a big disc herniation. You got to fix this." Spine surgeon told her, "Don't do it." So she said, "Okay, it's like, But she went home, started thinking about it. I got a big disc herniation. She sees herself as a young person.
Now, want to be disabled long term,
right? But I gotta take care of this. I don't want." And she's a proactive person, very accomplished. Just a lot. I'm sure a lot of folks can identify with that. So she then just says, "Okay, well, I gotta get this fixed." So she goes in doctor shops and eventually finds someone to fix this. And even though she was now by this time 80-90% better, within 5 weeks of having this injury, feeling completely better, she goes and gets fixed. And what does getting fixed in this generally mean? Generally, to fix a cervical disc herniation, we go through the front of the neck. We take out the disc. So you take out the portion that's pressing on the nerve, like this. So you get all that compression off. And then when you do that, you then fill in the space with bone and a spacer generally. And then there's generally some other type of instrumentation device. So either it's a plate or some kind of screws that go through the implant. But in her case, it was a plate. It comes in front like this.
Fusing that segment. And there's a screw coming across here and a screw coming across here. So actually, she was doing well, but she was doing well before she had the case. So she does well, but then what happens about 2 to 3 months later, she starts having neck pain. It starts getting worse. She's getting x-rays. And what they're noticing is what's called a slower delayed fusion. So what's happening is that this was not fusing as you would like to see. You want to see bone all the way across, and wasn't happening.
Wasn't happening. And this can happen even in patients with a one-level condition. It can happen about 5% of the time. The more levels you have, obviously, the more frequent. If you smoke, for example, it can cause you to have a higher risk. But anyway, bottom line is by about 4 to 5 months out, she was having more and more symptoms. So she went and saw another surgeon again. They said, "Well, this is not fused. We've got to fix it." But now to fix it, we're going to actually deal also with your lower level, which is somewhat degenerated. Even a 28-year-old, when they're not exercising, they're not fit, they're not careful of their ergonomics, you can develop some degenerative conditions very easily, even at age 28. So what happened was the surgeon then said, "Okay, let's extend your fusion to these levels." So what they did is take then and fuse this segment too. So now we're fused at this level also. And then then he revised the plate to come up here. And because he had to redo the plate,
you got to add extra screws going level below. And then this screw, though, unfortunately, hit and came into the next level up, So then this started to degenerate quicker. So she did well again. She's 28 by now. She's 28 and a half, almost 29. She's doing better. She's feeling pretty good. But then this level degenerates. So now we're talking. So from initial impact, she had 5 weeks later, she had the first surgery. Second surgery, she had 9 months later. 5 months after that, she has yet another surgery. And then now they extend it up to this level now.
Oh, boy.
So now you're talking even one more level to be done. And they take out that screw, reposition it. And this can happen. I mean, even the best of hands, screws can be misplaced. Fusions can't take.
Part of surgery.
It's part of surgery. And surgery is, I mean, don't get me wrong. Surgery is great for when you really need to have it. But look at her case now. She's 29 and she's got what? A three
levels fused.
Yeah. So what do you think of a case like this? I mean, what is this? This really hit me. So I'm wondering how does it impact you when you think?
To me, you think this was such a pivotal decision in her life. She probably didn't realize the impact when she made that decision. She was scared, saw the MRI, knew that there was compression, and didn't realize that this could be a path that there's no turning back. That's when I look at this case, I see, oh gosh, we want everyone to realize once you take that step, and when it's needed, it's fantastic, radically changes people's lives, and the majority of the time that happens. But when potentially it's not, you could go down this path that you can't go back.
And remember how she was doing 5 weeks in, 4 weeks, like 3 weeks, she's almost 80, 90% better. Yeah. I mean, so, and we know what happens with discs, they resorb. And so it's easy, right? We're all so used to seeing scans. We don't realize that when people see it, they really feel like that's their picture of them, right? So it's almost like, if you want to fix yourself, you have to fix your image.
Yeah. And maybe that's the simple takeaway here is that you are not your scans. It's just one snapshot and it will change over time.
Yes. And it's how you think about things. Once you focus on the negative, fixate on this problem, being this one disc herniation that was already resorbing, can completely overtake your life. And you keep searching, you're going to get it fixed, and something else is going to potentially happen. So this was a very instructive case to me, and it really it hit me how important it is to talk to folks about everything, about the whole person. This leads to our other case, Mr. Steve, who was an avid biker, 47-year-old guy. And he's an interesting guy because he was very active. He'd taken some spills off his bike, but otherwise very, very, very healthy. And he came in, he started having back pain, thinking, it's just my posture. I'm in this position. I'm riding so hard all the time. But then it got worse. He started developing what we call a foot drop, which is where your foot, as you place it, essentially flops, so it becomes weak. So the leg pain and intensity, they got worse and got to the point where it started this weakness. So, but then what happens is that he is actually starting to feel like, this pain's getting better, but my foot drop isn't. And we've seen this a lot, right? In other instances where things delay, right? Your scans or everything else don't necessarily follow. So we're not that concerned about it, thinking it's okay. So he goes and sees a couple surgeons and he gets an MRI scan. They notice that, he does have a disc herniation. So if you look at your sciatic nerve, it's made of different fibers. This is L4, L5, S1, and they all form into the sciatic nerve and they pass down to your leg. Well, at L4-5, if you get a disc herniation that pinches on this nerve, it can cause a foot drop of the L5 nerve root, because that L5 nerve root goes to the foot, that pulls the foot up. So he saw this, but he goes to a surgeon and says, but doc, you got to fix this. He says, you have painless weakness. And a lot of us, as surgeons, painless weakness, we generally leave alone because that means that whatever's happened to the nerve has happened. There's not much else we can do with it. And you've seen the shoulders and backs and necks. It has the same thing. So then what happened was that he gets an EMG, a nerve study, to follow the improvement of the nerve. Very interesting finding. It was the nerve study, and this EMG study is what's called an electromyogram. and they also do a nerve conduction study to see how is this nerve working along its whole course, not just up here. And what they noticed is that instead of it showing impulses that would implicate this is the problem,
Which is what he thought.
it actually implicated right here where the nerve passes by the leg, by the fibula, and it's very exposed. And a lot of times direct impact injuries, trauma right here, or just time and a lot of repetitive stuff can cause what's called a perineal neuropathy. And so that was the reason for it. So this happens a lot, and you've seen this in necks and shoulders a lot, and low back, where the nerves can get tight. If you look at where the nerve here passes through the pelvis, right here, there are muscles that come through here, one called the piriformis, where the sag nerve has to pass through. Well, your nerve can be caught there also. So if you're not thinking of everything, you can start pigeonholing yourself thinking, well, it's got to be this. And the MRI scan showed this. Well, how about this?
So when you're talking whole person, you mean psychologically understanding everything, understanding your emotions that base your decisions, but also anatomically your whole person as well.
Right, exactly. And that's a great segue to exactly what is really one of the points that we notice in spine so much is just what you were mentioning right there, is that your thoughts, which is obviously the way in which you think about everything, is going to be always affecting a lot of things. It affects, number one, your emotions, right? If you have thoughts that are disturbing, if they're affecting you, well, it's going to affect your emotions. Well, what's that going to do too? That's going to also affect your behavior, right? Because then you will act based on how you're feeling and you're thinking, right? So this affects this, then affects this. But then what happens, a lot of times when you behave a certain way, right? Let's say you feel confident, you're behaving in a confident way, that affects your thoughts. It also affects your emotions. You feel confident, you feel relaxed. So this plays the other way. So all of these, your emotions play back on your thoughts and your behavior. This is like a eternal circle that can really be beneficial in treating people, but also could be
totally detrimental.
Yeah. Exactly. So we have to really be thinking about this all the time, affecting people's thoughts, emotions, behavior, and this is using this type of paradigm is what we call CBT, or cognitive behavioral therapy, where when you start affecting negative thoughts and start addressing them, you start then shedding light on improving your emotions, improving what you do in your behaviors. And these can feed into feeling better. This type of treatment has been good for depression, anxiety, for back conditions. And it's very, very, very much a stalwart in what we use a lot in clinics to really help people understand their condition.
Not just going into rehab to think I'm going to just fix the problem because it's in my leg or my back or my shoulder, but actually thinking more holistically.
Yes.
Not focusing on this important pathway. Okay.
Actually, and
great.
Also, like using this episode of back pain as almost like a barometer, saying what's wrong, what am I doing wrong? There could be a lot of things, right? If think of all the things. That's what we're going to get into a little bit. This is kind of our breaking out point into our other chapters, which include all of the specifics of the different aspects that affect the spine, strengthening, posture, mind, body, all those things. We're going to go into much, even bigger depth. But to understand this paradigm and understand how this affects you, every time you decide on a treatment, you got to be thinking this way.
Yeah. Don't be thinking transactionally and narrow. Here's a problem, fix this problem. Take a step back, zoom out to understand it more holistically.
Exactly. So for example, like when you're talking about this to someone about surgery, it's going to be very different if they're, let's say, very sedentary and they don't need to run or jump or do anything. You're probably not going to do an ACL reconstruction on someone like that. Why would they need it? They don't need to cut. Same. So your goals are very important too. So this all these things come into effect, and then the way you're thinking about it. So I hope that everybody understands that this portion of ways of looking at your spine are incredibly important anytime you decide to do any kind of intervention. So now let's go on to speaking of like intervention and things where we want to be able to affect the trajectory of what happens. If we look at time here, and let's look at disability here. What happens in a lot of conditions is that early in life, obviously, most of the time, a lot of these degenerative conditions, they're okay. But what happens at some point is that we all gradually will decrease in our function to some degree as we get older. But what happens to the ones who don't do it well? And let's say the main areas that are chronic diseases, like number one is mental and cognitive problems. Another big one is cardiac problems. Another big one, musculoskeletal. So what happens is that at some point, some people get this relatively increased and accelerated rate of degeneration that occurs in them. And then in some people at some stage, they get a rapid deceleration. So now let's talk about this in different factors. Like for example, in whether it be for cardiac conditions. Give me an example of what you would think would be like something that wouldn't affect you in this early stage that would be the precursors of a bad disease for the heart.
High blood pressure.
Right. Okay. So high blood pressure can cause what can it cause? Hypertension, these things can cause mild issues with early on. These changes, by the way, start occurring around 35 to 40. Age 35 to 40, not very late in life. If you leave this alone, you will start hardening your arteries. You start developing some plaque. So you may not know this. It can take 20 years for this latent phase to be. So that's let's say for the cardiac conditions. We put the cardiac conditions in red. Then for the mental conditions, like what would you say would be like a sign that that mentally there'd be an issue?
Starting to withdraw, lack of social engagement
or things like that. So you start having these subtle effects early on, and then what happens is over 20 years you develop this condition called mild cognitive impairment, which really significantly affects depression and other things like that. And this is when the tangles in your brain and the ways in which the different neurons attach start getting clogged up. Very similar to how your arteries get clogged up. Very similar to how your muscles start losing their muscle fibers and start getting replaced by fat and fibrous tissue, like scar.
So you're trying to say that there's a common thread here.
Exactly.
So when you're talking about such conditions that affect almost everyone, is it neurologic, cardiovascular, musculoskeletal?
Right. Yes, and that's what's so interesting. If you look at this is why the whole person is so important to think about, because all of these chronic diseases have a common thread. And if you look at this initial phase, you have a lot more effect on the condition. This middle phase is harder. This late phase is very, very hard. So, what happens in what you and I have been trained the most to do? Where do we really affect things in this?
I think healthcare in general, we've been great here.
Right. So where would this be in cardiac? This would be like
an MI, a clogged artery.
MI, myocardial infarction, heart attack. Okay. And how about for cognitively? What would that be?
Putting them on meds for their Alzheimer's,
right?
Which we know has very, very little effect on quality of life.
Right. Dementia, severe dementia. And
I guess you were going to mention here too, if it was musculoskeletal, what is clearly something musculoskeletal, like obesity.
Obesity, right, can significantly affect that. But then what happens here is that this patient, what are the symptoms here for the patient with cardiac condition? Maybe nothing. Maybe their exercise tolerance gets a little less.
they're not doing as much as they could. Mentally, they may, not be as sharp as they used to. Here, they may have a couple episodes of back pain, nothing severe, right? Something where they have it, maybe even it's severe, but it's self-limited. It goes away.
Right.
So this is in the mild phase. If you're not watching this, it then becomes to where you're losing work. You're not able to work as well. You're not able to do you're not able to walk as well. Your function's impaired. So then you have mild cognitive impairment. You have issues with work when it comes to musculoskeletal. And as far as the heart, this is when people start getting the early hardening of the arteries. And this is where their exercise tolerance, and then they start with this is where they get stents and other things like that. And you really want to be affecting things in this middle region and hopefully further in this area, because this is where this 20-year gap is where you can do a lot if you listen to your body, listen to all the different body parts and all the different organ systems within your body. That's where I would like everybody to really focus their energies.
But what you're really telling us is that for people with back pain, you're not just changing your back pain trajectory. Right. If you affect these modifiable factors, you're actually improving your cardiovascular risk.
Excellent.
You're improving your cognitive. So tell me a little bit more about that, because I think that's one of the key points we want to really drive in today.
Right. Yeah. That all of these chronic factors have the common thread of the lack of, if you look at all of the major factors, it comes down to psychologically being affected, effort, exercise, challenge. Your body's used to that in every aspect, in your mind, in your heart, and in your muscles. Yeah. Everything needs to be challenged. It needs to get to another level. If you're not challenging it, it withers away. So it's common in every one of these disease processes.
So should I list these factors? You can tell me which it applies to, and we'd love to.
Absolutely. I lost my eraser. I don't know where that eraser went. So So let's talk about these factors now. So we had those three factors we were talking about. Number one was cardiovascular. 2 was mental. Okay, and 3 was musculoskeletal. Okay, so you really you hit it on the head when you were talking here about hypertension for cardiovascular. That was a big deal. So you got hypertension, click for it causes high and then for the social you hit for, let me go put this here, social. It was really affected the mental aspect of things. And then for musculoskeletal, we talked about strengthening, and you talked about strength and
obesity
and actually that's what we talked about, obesity. Sorry, we're gonna make a little bit of a call there, but look at these factors though. You've heard about hypertension affecting other things than just cardiovascular, right?
Yeah.
So what is the risk factor for also?
Is it neurologic?
Absolutely. Patients develop Alzheimer's at a much higher rate when they have hypertension because it affects the small vessels in their brain.
Yeah.
So that's a big factor. What's another factor cardiovascular-wise that you would think, okay, that's a big factor cardiovascularly, but it actually could be affecting these two aspects also?
Smoking.
Exactly. Big one. Smoking. Huge musculoskeletal, cardiovascular, and mental. All these things. You start looking at this and you start seeing the common thread. What other things can you think of?
Let's see here. Excessive alcohol, lack of exercise, stress, sleep.
All these. ETOH, alcohol has a significant effect on all three of these. Sleep, major effect when you're talking about this. So with sleep, also huge effect on the mind, but also cardiovascularly. If you're not sleeping well, if you're not getting enough of deep sleep and REM sleep, your body does not regenerate.
and especially musculoskeletal wise, you don't have the energy there. You can't get to do anything else. So you look at all these things, they have very, very common threads all the way through. But so what else can we do? Every one of these things, though, have individual modifiable risk factors. And that's really where if you have a spine problem, that's where you have to maybe do a couple things that are special to spine. What would be an example of something special to spine that wouldn't necessarily affect cardiovascular or the mental?
Ergonomics, strengthening. Although you could say strengthening is going to be good for your mental, emotional, and neurologic too. But yeah, probably.
That's a great one. So ergonomics is a great one. It's really very, very specific for musculoskeletal. So it's the way you sit, the way you get up, the effect you have on the way in which you carry things, whether it's far away from you, close to you, whether as you are getting up, you put strain on your back to pull yourself up versus using your glute muscles to appropriately get up. When you lift, where you put a curvature in your back or not, makes a big, big difference. So these are things that are very musculoskeletal specific that we can then train. So this is where I think you got to affect. This is why the whole person is important, but also getting into the specifics of your condition. And there are things in the mental aspect, like, for example, mental games, memory games, things like that. For cardiovascular, eating less cholesterol, things like that. So there are a lot of specific ones, but if you hit the main ones, you've won a lot of the battle. Again, treating what we talked about at the beginning, treating the whole person.
So the takeaway here, if I'm hearing you correctly, is that if I get back pain, I have an opportunity, if I look at this holistically, to improve my cardiovascular health, improve my risk of getting Alzheimer's down the line. Same thing, if I am treating my heart and I do the right things, my risk of back pain is less. And we want to be in this phase, which is much more preventative before the decline begins, investing the time early.
Exactly. And there's good news in it for the spine and musculoskeletal wise here versus, for example, dementia.
Right.
Because the good news is we can still, even in the musculoskeletal stuff, we can affect things at this later age a lot more than you can. Like right now, there's really nothing available in the dementia realm. Right. A lot of times in the cardiac realm, there's really not much available except for doing stents or open heart surgery. We can still show a significant improvement in muscle strength, balance, and musculoskeletal factors way deep into this problem, where a lot of this can be reversed with proper strengthening, even in the 70, 75, 80-year-old who are in this pathway. We've noticed significant improvements. So I'm hoping, and they're doing work on these areas to also shift this curve over so it's more effective. But, that's the kind of stuff that the message to you and who are listening is really to think about this whenever you're making, from the beginning when we talked about the patient who at any age needs to have something done. Make sure you really need to have it done. Make sure you're not panicking. Make sure you're not jumping to conclusions. Make sure you're not perseverating on the problem. And then when you're looking at it, make sure that you're really looking at all the things that can cause your problem. There's so many things that cross over in the body. You don't want to be fooled by that. And then do all you can to fix it before you do something intervention-wise. And that's if we learn that, I think we're way ahead of the game.
Yeah. Thanks everyone for your time. Really appreciate you joining. Please send any questions. We look forward to seeing you all in the next webinar. Thanks.
Thanks, everybody.